Imagine walking into your neighborhood pharmacy, handing the pharmacist a prescription written by a doctor you trust, and having your health insurance card swiped. You expect a straightforward business transaction. A manufacturer produced a life-saving chemical, a doctor prescribed it, an insurer helped offset the cost, and a local pharmacist dispensed it. But hidden inside that brief digital beep, as your card scans, lies an invisible, sprawling, high-stakes casino. In the milliseconds it takes for the transaction to clear, an unseen behemoth reaches directly into your wallet, dictates what your doctor is allowed to prescribe, decides whether your local pharmacy stays solvent or goes bankrupt, and extracts billions of dollars in pure profit from your life-threatening illness. These are pharmacy benefit managers, or PBMs, the colossal, secretive middlemen dominating modern healthcare. They operate in the dark, pull the strings of a multi-trillion-dollar pharmaceutical industry, and remain virtually unknown to the very patients whose lives depend on them. To understand how American drug prices spiraled into absolute absurdity, one must trace the historical origins of the PBM. In the late 1960s and 1970s, pharmacy benefit managers were born out of a simple, noble logistical necessity: administrative efficiency. As prescription drug coverage expanded across employer-sponsored health insurance plans, paper claims began flooding insurance offices. PBMs emerged as basic administrative paper pushers. They processed paper claims, negotiated modest bulk volume discounts with drug companies, and built pharmacy networks so workers wouldn't have to mail paper receipts to get reimbursed. For decades, they operated as quiet, low-margin service providers working modestly in the background of the medical supply chain. However, as the pharmaceutical market exploded in the late 1990s and 2000s with blockbuster biological drugs and skyrocketing prescription volumes, PBMs underwent a silent, predatory evolution. They realized that sitting precisely at the intersection of all four major healthcare players, drug manufacturers, health insurers, retail pharmacies, and patient beneficiaries, granted them an unbelievable structural power. Whichever entity controls the crossroad controls the tollgate. PBMs transitioned from benign claims processors into corporate behemoths, capable of making or breaking multi-billion-dollar pharmaceutical corporations and setting the price of human survival. Today, the illusion of market choice in pharmacy benefits is complete. Through a series of massive, anti-competitive mergers and vertical integration, three monolithic corporate giants now control over 80% of the entire prescription drug market in the United States. Caremark, owned by CVS Health, Express Scripts, owned by Cigna, and Optum Rx, owned by United Health Group. Notice the structure. These are no longer standalone administrative companies. They are vertically integrated corporate leviathans that simultaneously own the health insurance company paying the claim, the PBM managing the claim, the mail-order or specialty pharmacy filling the claim, and in many cases, the physical urgent care clinics and medical practices treating the patient. They operate as judge, jury, executioner, and toll collector in a closed-loop monopoly system designed to siphon capital at every single turn. The core engine driving PBM profitability, and the primary reason your medications cost an arm and a leg, is an outrageous mechanism known as the rebate game. To the average consumer, a rebate sounds like a consumer-friendly discount. A manufacturer offers a price reduction, and the savings are passed along to the shopper. In the upside-down world of PBM drug pricing, however, a rebate is not a discount. It is a legal, reverse kickback scheme that actively incentivizes higher drug prices. Here is how the scam operates. PBMs control the formulary, the sacred, highly guarded list of medications that an insurance plan agrees to cover. If a drug manufacturer's product is left off the formulary, that drug is effectively dead in the water, inaccessible to tens of millions of insured Americans. Because PBMs hold absolute control over formulary access, they can demand massive rebates from pharmaceutical manufacturers in exchange for giving their drug a favorable spot on the list. If Pharma company wants their drug on the formulary, Instead of pharma company BTK's competing drug, company A must hand over a massive cut of the drug's price to the PBM. Herein lies the structural trap. PBMs do not pocket a flat fee, they keep a percentage of the rebate, or calculate their administrative fees based on the drug's initial sticker price, known as the list price or wholesale acquisition cost, WAC. Therefore, the higher the list price of a drug, the larger the dollar amount of the rebate the PBM can demand and pocket. If a drug manufacturer introduces a life-saving medication with a reasonable $100 list price, the PBM makes a tiny fee. But if the manufacturer inflates that list price to $1,000 and offers a $700 rebate back to the PBM clears hundreds of dollars in profit. The system actively punishes low-cost drugs and rewards inflated sticker prices. Consider the devastating, real-world impact on insulin, a century-old hormone essential for the survival of millions of diabetics. The cost to manufacture a vial of modern insulin is estimated between $2 and $6. Yet over the last 2 decades, the list price of insulin skyrocketed by over 1,000%, topping $300 to $400 per vial. Why? Because manufacturers were locked in a bidding war to satisfy the rebate demands of the big 3 PBMs. When drug manufacturers attempted to release lower-priced generic or biosimilar insulins, PBMs routinely refused to place those cheaper options on their formularies. Why would they? Lower list prices mean smaller rebates and lower profits for the middleman. Patients with high-deductible health plans, or those who are uninsured, are forced to pay the artificially inflated $400 list price at the pharmacy counter, a price artificially pumped up to feed the PBM's rebate engine. The exact same playbook dictates the pricing of EpiPens, auto-injectors containing a few cents worth of epinephrine used to stop fatal allergic reactions. When the list price of an EpiPen 2-pack surged from roughly $100 to over $600, public outrage rightfully targeted the manufacturer. But hidden in the shadow behind the podium were the PBMs, who were extracting over half of that $600 sticker price in hidden rebates and administrative fees just to grant the device space on insurance formularies. The middleman creates the fire and then charges the patient for the water to put it out. If ruining the financial stability of patients through rebate games were not enough, PBMs have weaponized another predatory mechanism to destroy their main physical competitors, independent, community-owned pharmacies. This mechanism is known as spread pricing, a financial trick that borderlines on outright extortion. When an insured patient fills a prescription at a local pharmacy, the PBM acts as the clearinghouse. Under spread pricing, the PBM charges the health plan sponsor, such as an employer's health plan or a state Medicaid program, a high price for a prescription drug, say $150. However, when the PBM turns around to reimburse the independent pharmacy that actually bought, stocked, and dispensed the medication, the PBM pays them a fraction of that amount, say $15. The PBM quietly pockets the $135 difference, the spread. Without manufacturing a pill, maintaining a physical storefront, or providing a single second of patient care. Even worse is the phenomenon of negative reimbursement. Independent pharmacists across the nation routinely log into their software systems to find that a PBM has reimbursed them less than what it cost the pharmacy to purchase the drug from the wholesaler. A pharmacist might purchase a cancer therapy or a specialized antibiotic for $500, dispense it to an insured patient, and receive a mandatory reimbursement check from the PBM for $420. The pharmacist literally loses $80 out of their own pocket just for fulfilling their oath to care for their patient. Refuse to fill it, and they violate their insurance network contract. Fill it, and they bleed to death financially. Why would PBMs deliberately starve independent pharmacies? The answer becomes glaringly obvious when you remember vertical integration. The mega PBMs own their own competing retail chains and mail-order specialty pharmacies. CVS Caremark, for example, is owned by the same corporate parent as CVS Pharmacy. By crushing independent pharmacies through negative reimbursements and spread pricing, PBMs systematically force small neighborhood pharmacies into bankruptcy. Once the independent pharmacy closes its doors, the patient has no choice but to transfer their prescriptions to a chain pharmacy owned by the very PBM controlling their plan, or be forced into the PBM's proprietary mail-order delivery system. This is not a theoretical corporate game, it is an ongoing execution of community health. Over the past decade, thousands of independent community pharmacies have shuttered across urban neighborhoods and rural towns. In vast swaths of rural America, these closures create vast pharmacy deserts. Elderly patients, those without reliable transportation, and individuals managing complex chronic illnesses are left with nowhere to turn. The friendly neighborhood pharmacist who knew your medical history, answered late-night calls, and offered personalized advice is systematically eradicated, replaced by a cold, automated mail-order distribution facility thousands of miles away. How has an industry, this predatory, managed to operate in plain sight for decades without triggering massive antitrust intervention or public revolts? The answer lies in an intricate, multi-layered shield of statutory loopholes, aggressive lobbying, and draconian corporate non-disclosure agreements. In 2003, Congress passed the Medicare Modernization Act, establishing Medicare Part D. In an effort to curb government spending, lawmakers outsourced the administration of prescription drug benefits to private entities, handing PBMs the keys to the kingdom. Crucially, PBMs operate under a bizarre legal anomaly. Unlike financial advisors, healthcare providers, or corporate officers, PBMs are generally not classified as legally bound fiduciaries to the health plans or patients they represent. That means they have no legal obligation to act in the best financial interest of the employer funding the healthcare plan or the patient swallowing the pill. They are legally permitted to maximize their own corporate profits at the direct expense of the people paying for the coverage. To keep the public and policymakers in the dark, PBMs enforce ruthless trade secrecy. Contracts signed between PBMs, drug manufacturers, health plans, and pharmacies are guarded with intense legal paranoia. They contain strict non-disclosure agreements that forbid pharmacies from revealing how little they are reimbursed, and forbid drug companies from disclosing the true size of the rebates paid behind closed doors. Until federal legislation stepped in recently to ban the practice, PBMs routinely bound pharmacists with infamous gag clauses. Under a gag clause, if a pharmacist noticed that a patient's cash price for a generic drug was $8, but their insurance copay dictated by the PBM was $30, the pharmacist was legally forbidden from telling the patient that paying cash would save them $22. If the pharmacist dared to help the patient save money, the PBM could terminate their contract, instantly bankrupting the pharmacy. When state regulators or courageous corporate whistleblowers try to pull back the curtain, PBMs deploy an army of high-powered lobbyists and legal counsel. They spend tens of millions of dollars annually convincing federal and state legislators that any government regulation will destroy free market competition and raise costs for consumers, a breathtakingly cynical claim from an oligopoly that actively suppresses competition and inflates costs for a living. The story of pharmacy benefit managers is a stark warning of what happens when essential human needs, life-saving medicine, biological survival, and community care, are surrendered to unchecked corporate financialization. PBMs did not invent medicine, they do not conduct scientific research, they do not manufacture drugs, and they do not treat patients. Yet, through regulatory capture, corporate consolidation, and deliberate opacity, they have positioned themselves as the supreme rulers of the American healthcare ecosystem. Every single day across the country, impossible tragedies play out quietly behind closed doors because of this system. A young adult aging out of their parents' insurance plan tries to stretch a single vial of overpriced insulin by rationing doses, only to succumb to diabetic ketoacidosis. A mother stands at a pharmacy counter crying because her child's asthma inhaler requires a $400 out-of-pocket payment, a price inflated by a rebate battle between executives in glass boardrooms. A third-generation family pharmacist locks the front door of their small-town business for the last time, driven into insolvency by predatory negative reimbursements. Change, however, is finally looming on the horizon. The tide of public awareness is turning. Federal agencies, including the Federal Trade Commission (FTC), have launched sweeping antitrust investigations into the anti-competitive practices, vertical integration, and rebate structures of the big three PBMs. Bipartisan legislation is gaining momentum in Congress to demand absolute price transparency, outlaw spread pricing, ban rebate-linked formulary placements, and hold these shadowy middlemen accountable as legal fiduciaries. Unmasking the PBM cartel is not merely an exercise in financial regulation or administrative policy. It is a fundamental moral imperative. Healthcare cannot function when human life is treated as leverage in a hidden financial game. The shadow middlemen must be brought out into the light, stripped of their predatory tools, and held accountable. The health, safety, and economic security of millions of Americans depends on tearing down the invisible toll booth standing between patients and the medicine they need to survive. Think this story was shocking? The deeper you dig, the darker it gets. Watch our investigative series exposing the rise and collapse of powerful political empires. Hit subscribe to Corrupt Roots and tell us in the comments, what hidden trail of corruption should we uncover next?